Hi guys, this is Dr. Pritesh Singh, author of Surgery Sense, AIMS Sense, NEET Sense, INI-CET Sense, Quick Review of Surgery, National Level Surgery Faculty and Faculty of Surgery at PrepLadder. So we are going to discuss the surgery question of INI-CET November 2022. These are my best-selling titles: Surgery Sense, AIMS Sense, NEET Sense, INI-CET Sense and Quick Review of Surgery. So let's start with question number 1. All of the following are relative contraindications for breast conservation surgery except. So you know, this breast conservation surgery, it is done in which particular stage? Breast cancer, what is the stage? Early invasive breast cancer, and the stage is stage 1, stage 2A and stage 2B. Early invasive breast cancer, stage 1, 2A, 2B. What we do in breast conservation surgery, we perform lumpectomy, or we go for wide local excision, or we go for quadrantectomy. And after that, we go for sentinel lymph node biopsy and we give radiotherapy. Clear? There are relative contraindications and there are absolute contraindications. So question is, all of the following are relative contraindications except. See, if there are multiple tumors in the same quadrant, it's a relative contraindication. If there is previous history of radiation, that is also one of the relative contraindication. And large tumor in small breast, that is also a relative contraindication. So if you see multiple tumors, previous history of radiation and tumor more than 4 cm means large tumor, these are relative contraindications. But if you see option number C, axillary node less than N1, it means lymph node is not involved and that is not a relative contraindication. So this is not a relative contraindication. Rest all are relative contraindication. So what is the correct answer for this question? Option number C. So see, in the notes also, you have seen in the lecture videos also, we discussed it many times. What are the absolute contraindications? Pregnancy, 2 or more than 2 tumors in different quadrant, or there is diffuse malignant appearing microcalcification. What do you mean by this diffuse malignant appearing microcalcification? It means patient is having multicentric disease. And if there is persistently positive margins, means you are going to resect the tumor, still the margin is positive. And if there is history of exposure of therapeutic radiation, what do you mean by therapeutic radiation? When patient received radiotherapy for some malignancy and the radiotherapy dose was curative, that is therapeutic radiation. The relative contraindications are history of collagen vascular disease like scleroderma or active lupus erythematosus. Here you can see multiple tumors in same quadrant, or indeterminate calcification. Indeterminate calcification means the nature of calcification is not known. And here this was the in option large tumor in small breast. If the patient is having large pendulous breast, it's very difficult to give uniform dose of radiotherapy. And if tumor is centrally located, means located beneath nipple and areola, so it's very difficult to reconstruct nipple and areola. So see the question again here, all of the following are relative contraindications except the correct answer is C, axillary node less than N1. Now see question number 2, which of the following is true? Which of the following is true about basal type of breast cancer? You know that the basal type of breast cancer is also known as triple negative breast cancer. Basal type, it is also known as triple negative breast cancer. It means all the 3 receptors are negative. ER negative, estrogen receptor negative. PR means progesterone receptor, that is negative. And HER2 new is also negative. So this is triple negative breast cancer. So what is the correct answer here? It is D. This question, this is luminal criteria, are also known as molecular classification of breast cancer. This question is frequently asked both in surgery as well as in pathology. So have a look of this luminal criteria. So first of all, LUM A or luminal A. So in luminal A, ER is positive, progesterone receptor is positive, but HER2 new is negative. Since ER and PR, these are positive, so this is also known as double positive. Clear? Then there is LUM B. In LUM B, all 3 are positive, ER, PR, HER2 new. So this is what? This is known as triple positive. Then another type is normal breast-like, which is ER positive and well differentiated. And then there is basal cell type or basal type, which is triple negative breast cancer. And this triple negative breast cancer, obviously, it is negative for all three, ER, PR as well as HER2/neu, but it is positive for epithelial growth factor receptor, that is EGFR. It is positive for myoepithelial markers and cytokeratins. You have to remember which one? Cytokeratin 5, 6 and 17. And then there is HER2/neu type, which is ER negative, PR negative. It's positive only for HER2/neu. Clear? So these are the types of luminal criteria. In this, what is the most common type? So you know, if any classification starts with 1, 2, 3, 4, 5 or A, B, C, D, E, what is the most common type? If it starts from 1, 2, 3, 4, 5, usually it is type 1. And if it starts from A, B, C, D, E, usually it is type A. So the most common type is luminal A, and this is having best prognosis. Whereas the worst prognosis, it is seen in HER2/neu type, because HER2/neu positivity itself is a poor prognostic factor. Question number 3. Question number 3. A 34 years old female with right breast lump and the size is less than 4 cm. Right breast lump, size less than 4 cm. See the age, 34 years old female. On examination, there is no nipple retraction, no skin color change. It means the finding of malignancies are not there. Patient is also young. On mammography, there is calcified fibroadenoma. This is important. What? On mammography, there is calcified fibroadenoma. Clear? So on mammography, calcified fibroadenoma, you tell me it is suggestive of which finding? Benign or malignant? So obviously, it is suggestive of benign finding. So on mammography, there is benign lesion which is visualized. What is the BI-RADS score? Full form of BI-RADS? Breast Imaging Reporting and Data System. And if it is 0, BI-RADS is 0, it means incomplete assessment. If it's 1, it's negative. If it is 2, benign. 3, probably benign. 4, suspicious. 5, highly suggestive of malignancy. And 6, biopsy proven malignancy. So since it's benign, you tell me what should be the BI-RADS score? The BI-RADS score should be 2. Clear? It's very, very important. You have to remember the various categories of BI-RADS score and how much is the risk of malignancy associated with various categories of BI-RADS. Have a look. So we discussed, if the category is 0, that is incomplete assessment and some additional imaging is required. Some additional imaging is required. If it is 1, it means mammography is negative, and obviously we advise what? Annual mammography. If it is 2, this is benign. And if it's benign, again what is recommended? Annual mammography, right? In category 1 and 2, how much is the risk of malignancy? 0%. Whenever it's 3 means probably benign. Here, what is recommended? Short-term follow-up is recommended. And here the risk of malignancy is more than 0 to 2%. Then category 4 is suspicious, which is further divided into low suspicion, moderate suspicion and high suspicion. If there is low suspicion, how much is the risk of malignancy? More than 2 to 10%. If there is moderate suspicion, risk is more than 10 to 50%. And whenever there is high suspicion, risk of malignancy is more than 50 to 95%. We discussed type 5, category 5. This is highly suggestive of malignancy. And when it's highly suggestive of malignancy, what is recommended? Yes, intervention is recommended. And if the score is 6, it means it's biopsy proven malignancy. And how much is the risk of malignancy if BI-RADS score is 5? It's maximum more than 95%. So you have to remember, because the BI-RADS is frequently asked, sometimes in surgery and sometimes it's integrated question with radiology. Now question number 4, which of the following is not used for diagnosis of breast carcinoma? You know that in breast cancer, what we perform triple assessment. In breast cancer, we perform triple assessment. And you tell me, what are the components of triple assessment? In triple assessment, first, clinical signs and symptoms. So we take history and examination. So it's clinical. That is what? Signs and symptoms. Okay. After that, what we perform? We perform imaging. And in imaging, what we are going to do? Mammography and ultrasound. So what? There is imaging. And in imaging, what is advised? Either mammography or ultrasound. Mammography or ultrasound. And after that, for confirmation, we go for tissue sampling. So we go for tissue sampling. And in tissue sampling, what's done? Biopsy, or second option is FNAC. You know, this is triple assessment. These are the components of triple assessment. And how much is the positive predictive value of triple assessment? The positive predictive value of triple assessment, that is 99.9%. Simple. So which of the following is not used for the diagnosis of breast carcinoma? Obviously, we go for radiological assessment, we go for clinical examination, we go for biopsy. PET-CT is not done. PET-CT is not done. So correct answer for this question is option number A. Now see question number 5. Which drug is used in goiter patients to reduce bleeding before thyroidectomy? So we start actually Lugol's iodine. And this Lugol's iodine started 7 to 10 days before surgery. And how many drops? We start 3 drops twice daily. 3 drops are given twice daily. And how many days before surgery it should be started? So we are giving it for 7 to 10 days pre-operatively. So what is the function of this Lugol's iodine? How it's going to work? It is going to decrease the vascularity of the gland. And if it decreases the vascularity of gland, what happens? Obviously, it reduces bleeding during surgery. Second, it decreases the risk of intraoperative thyroid storm. Clear? So what? Correct answer is D. Why we give propranolol? Propranolol, it is because the patients of hyperthyroidism, they have sympathetic stimulation symptoms. So propranolol, it is used to control the sympathetic stimulation symptoms. Propylthiouracil, you know that it is one of the used anti-thyroid drugs in patients of Graves' disease, and one of the use of propylthiouracil that it blocks the conversion of T4 to T3, and that's why it is helpful in thyrotoxic crisis or thyroid storm. Clear? So correct answer for this question is Lugol's iodine, option number D. See what's written in shorts about Lugol's iodine. You can see here that Lugol's iodine solution or saturated potassium iodide. Imagine if Lugol's iodine is not given in the option, then the best alternative would be what? Potassium iodide. But it is what? Saturated potassium iodide. And generally administered beginning 7 to 10 days preoperatively. 3 drops twice daily. There are 2 functions. One, it reduces the vascularity of gland. And the second is it decreases the risk of precipitating thyroid storm. So that's the use of Lugol's iodine in patients of Graves' disease. Question number 6. Similar questions were asked previously, but this time they mentioned what? One additional feature. First, see, age, a 19 years. What's the age of patient? A 19 years old girl with 6 months swelling, which moves with deglutition with strap muscles invasion. So if thyroid swelling is moving with deglutition, most of the thyroid swelling moves with deglutition. There is additional feature of thyroglossal cyst. What? Whenever the patient is going to protrude the tongue, swelling moves up. This finding is not mentioned. And you know that thyroglossal cyst is congenital condition. This is congenital, but the age of presentation is 15 to 30 years. Okay, so let's first see the age criteria. If you first see the age criteria, generally papillary thyroid cancer, it is seen in 3rd to 4th decade, young patients. If you see follicular adenoma, medullary carcinoma, these are seen in 6th decade. So according to age criteria also, these 2 options are ruled out. If medullary carcinoma thyroid patients are young, they are having association with men 2A, 2B. It means there might be signs and symptoms suggestive of what? Pheochromocytoma. What else? hyperparathyroidism, and there will be positive family history which is not mentioned here. So obviously these are ruled out. Only thing against papillary carcinoma thyroid is generally it is not having this particular feature, strap muscle invasion. But if you see the image which was given in the exam, what there is optically clear nuclei. If it is optically clear nuclei, that is also known as what? Orphan NEI nuclei. So this feature is highly suggestive of what? Papillary thyroid cancer. So young patient, short history, and orphan NEI nuclei or optically clear nuclei. These are the findings which are suggestive of papillary thyroid cancer. So correct answer is B. You know, this papillary carcinoma thyroid, it is also associated with another important finding which is asked in exam. And what is that? This is dystrophic calcification. This is what? Dystrophic calcification, right? And not only in papillary carcinoma thyroid, dystrophic calcification is seen. That is known as what? Psammoma bodies. This is psammoma bodies. Not only papillary carcinoma thyroid, there are other malignancies also which are having these features. And how to remember? The mnemonic is PSM. Mnemonic is PSM. P means papillary carcinoma thyroid. P means papillary variant of RCC. S means serous cyst adenoma ovary. That is serous cyst adenoma ovary. And what is M? That is meningioma. Serous cyst adenoma ovary, and that is meningioma. That's M. Clear? Important points. So correct answer for this question is what? Option number B, papillary carcinoma thyroid. Now question number 7. Match the following with method of collecting the sample as mentioned below. So how you make the diagnosis of Marjolins ulcer? You know that Marjolins ulcer is low grade squamous cell carcinoma arising from burn scar or post venous ulcer scar. Clear? So since it is arising from scar tissue, which kind of biopsy is taken? We are going to take the biopsy from edge. So we take edge biopsy, or it's the wedge biopsy, because in the center there is scarred tissue only. So option number for A, correct answer is 1, thigh sarcoma. How you are going to make the diagnosis of sarcoma? Sarcoma's diagnosis is made by true cut biopsy or core cut biopsy. So what? For option number B, obviously what? Core needle biopsy. So B4, single cervical lymph node swelling. You have seen in surgery OPD, and we are discussing it also many times, that if a patient is having single cervical lymph node swelling, we go for excision biopsy. Clear? So that exactly what's the diagnosis we can make. So if there is single cervical lymph node swelling, you can go for excisional biopsy. For option number C, it's 2. And solitary thyroid nodule, solitary nodule on the thyroid. So for solitary thyroid nodule, the investigation of choice is FNAC. And what kind of FNAC is preferred? Ultrasound guided, especially if the swelling is small. So for option number D, it is 3. So what? A1, B4, C2, D3. So correct answer for this question is option number A, first option. See question number 8. Which of the following are associated with MEN2A syndrome? Frequently the questions are asked about MEN1, MEN2A, MEN2B. Frequently. You know that MEN2A, what is the other name? It is also known as Sippel syndrome. It is also known as Sippel syndrome. Okay, and two most characteristic features of Sippel syndrome is what? There is parathyroid hyperplasia leading to obviously what? Hyperparathyroidism. Hyperparathyroidism, and what else? These patients are having medullary carcinoma thyroid. Cafe au lait spots, optic nerve glioma, these are not seen. So correct answer for this question is option number A. Option 1 and 2 are correct. So option number A. What are the features of MEN2A? MEN2A is also known as MEN2, whereas MEN2B is known as MEN3. Other name is Sippel syndrome. All men are autosomal dominant. Apart from parathyroid adenoma or hyperplasia, medullary carcinoma thyroid, what? There is pheochromocytoma. These patients are also having Hirschsprung's disease and cutaneous lichen amyloidosis. So how to remember? MP in PHC. Mnemonic is MP in PHC. Medullary carcinoma thyroid, pheochromocytoma. Parathyroid hypoplasia or adenoma. There is Hirschsprung's disease, cutaneous lichen amyloidosis. What is the mutation responsible? Obviously, RET oncogene located on chromosome number 10. And they ask sometimes what is the mutated codon, and this is cysteine codon. What's the codon? Cysteine codon. So question number 9, identify the segment showed in the arrow. Frequently, almost every year, there is one question related to CT where you have to identify either the normal structure or the liver segments. So first see how we are going to divide the liver segment. In this picture, you can see that this is the liver segment. You can't see segment 1 from front. This is 2, this is 3, 4A, 4B, this is 5, 6, 7, 8. If you are taking the section from this level, if you take the section from this level, you can see what? 3, segment 4B, 5 and 8. And if you take a superior section in this level, you can see segment 2, 4A, 8 and segment 7. So in this picture, you can see that we are taking section from superior part of liver, superiorly. So here you can see segment 2, some part of 3, segment 4A, here 8 and 7. And if you take section a bit inferiorly, then you are going to find what? Segment 3, 4B, 5 and segment 6. Clear? Now see the level. Here, relatively inferior section has been taken. So what is this segment? This is segment 3. This is segment 4. This is segment 5 and this is segment 6. Clear? And above here the segment 2 is there. Here this is 6. So this will be 7. Here this is 8. This one is 4B. This is 4A. Clear? So what is the correct answer? This is the marked structure. So what is the segment? Obviously this is segment 5. So correct answer for this question is option number C. Question number 10. Identify the focal lesion on NC-CT abdomen. So this is NC-CT abdomen, and in this lesion what you can see? The whitish structures. Clear? In this liver lesion you can see the whitish structure. It means there are calcified structure. Okay. Out of these 4 conditions, in which case you will find the calcified structures? First you tell me. Obviously you are not going to find it in liver abscess, not in HCC, not in FNH. So it is hydatid cyst. And you know what kind of calcification is seen in hydatid cyst? The characteristic feature is after some times there is ring-like calcification. Ring-like calcification. Clear? So these are calcified structures because it is NC-CT. Whitish structures are calcified structures. So it is seen in hydatid cyst. Okay. What is the typical finding in HCC? You know that the investigation of choice for diagnosis is CT. What kind of triple phase CT? And on triple phase CT, what is the diagnostic appearance? Arterial hypervascularization with venous washout. And what kind of appearance is seen? What kind of appearance on FNH? This kind of appearance. This kind of scar is there. So what is this scar? This is central stellate scar. So for this question, correct answer is A. But since these are asked frequently in exam, have a look how these conditions look like on radiological investigations. See the first picture here. What kind of calcification you are going to see? Ring-like calcification in the periphery. So this is finding seen in hydatid cyst. Ring-like calcification seen in hydatid cyst. Here, this patient is having what? Liver abscess. The patient is having liver abscess. If you see the third image here, see this? Here, this kind of appearance is there. Right? It means what? This patient is having central stellate scar. So the patient is having, this patient is having central stellate scar. And central stellate scar, it is seen in many conditions, but it is seen in FNH also, focal nodular hyperplasia. So this is central stellate scar. Now see the typical appearance which is seen in HCC. This is the triple phase CT, and on triple phase CT, this is the arterial phase. Here you can see arterial hypervascularization, and here you can see what? Venous phase. So here what? Venous washout. So arterial hypervascularization with venous washout. Diagnostic appearance, this is seen in HCC. HCC, hepatocellular carcinoma. Question number 11. Which of the following is false? False in case of acute cholecystitis. Okay. So, preferential visualization of gallbladder on HIDA scan. HIDA scan is hepatobiliary immunodiacetic acid scan. And you know that this HIDA scan is the gold standard investigation. This is gold standard investigation for diagnosis of acute cholecystitis. Acute cholecystitis. So how we are going to make the diagnosis? Whenever we are performing HIDA scan, there is non-visualization of gallbladder within 30 minutes. Non-visualization. But what is the option? Preferential visualization. So no, it's actually non-visualization of gallbladder on HIDA scan. Gallbladder wall thickness more than 3 mm. There are many conditions in which the gallbladder wall is thickened, and one of the condition is acute cholecystitis where the thickness is more than 4 mm. You know that acute cholecystitis is characterized by a triad. And what's the triad? There is right upper quadrant pain. There is right upper quadrant pain. There is fever. And these patients have leukocytosis. Leukocytosis. So we are going to find leukocytosis also. And Murphy's sign is positive. What is Murphy's sign? On pressing tip of right ninth costal cartilage, patient catches the breath in inspiration. And what is the other name of Murphy's sign? This is also known as Nonin's sign. Murphy's sign also known as Nonin's sign. Clear? So this is B is correct, C is correct, D is correct. There is non-visualization of gallbladder on HIDA scan. So which option is false? Option number A is false. Second, in INI-CET, previously names this question was asked. What kind of question? Image-based question related to HIDA scan. How it looks like in acute cholecystitis. See, so if you see this image, this is the liver. Here, this is the gallbladder. This is the CBD. This is the small bowel. In this case, you can see that there is visualization of gallbladder. This is normal HIDA scan. But what? This is non-visualization of gallbladder. Why? This part of gallbladder, it's not visualized. So this is diagnostic of what? Acute cholecystitis. So diagnostic criteria for acute cholecystitis on HIDA scan. Here you can see what? Non-visualization. You can see non-visualization of gallbladder. Question number 12. Earliest sign in gallbladder carcinoma. Clear? So if you see earliest sign in gallbladder carcinoma, option number A, that is jaundice. Jaundice is also a late sign. Palpable mass is a very late sign, and ascites is seen whenever there is spread or the patients who are having metastasis. Colicky pain is the earliest symptom, right? So obviously colicky pain is not a sign, it's a symptom. So this is ruled out. Out of these three options, we have to choose jaundice, palpable mass, and ascites. So if you see the anatomy, this is the liver, and here this is the gallbladder. This is the gallbladder. Sometimes the patients who are having malignancy where? Patients who are having malignancy near neck. If there is malignancy near neck and this starts compressing what? CBD or common hepatic duct, then patient is having jaundice. So usually jaundice is not an early sign, it's a late sign. But if we have to choose one in these three, jaundice, palpable mass and ascites, we have to go for jaundice. Clear? Jaundice is late sign, but out of these three, relatively early. One specific condition, if a patient is having carcinoma gallbladder located at neck, then there is involvement of common hepatic duct, it is compressing common hepatic duct, then patient can present with jaundice. So correct answer for this question is option number A. And you can see what's written in Bailey. Patient may be asymptomatic at the time of diagnosis. Why these patients are asymptomatic? Because in 60% cases, the malignancy is located in the fundus. So if it is located in fundus, patient might be asymptomatic. Symptoms, if present, these are indistinguishable from benign gallbladder disease. Why? Initially, these patients, they have gallstones. Patients are having gallstones. And because of these gallstones, these patients are having biliary colic, or these patients are having signs and symptoms of cholecystitis. Here you can see jaundice and anorexia, these are late feature. palpable mass, it's a late sign. Okay. So if you see the question again, correct answer for this question would be what? Option number A. Question number 13. Similar questions were asked many times in AIIMS, specifically in AIIMS, and the question is related to sterile necrosis or infected pancreatic necrosis. Okay. Read the question. Patient is referred from outside hospital with necrotizing acute pancreatitis, right? With collection. So there is collection also on CCT abdomen. Patient is on vasopressors with BP 90/60. Means the condition of patient is not good, unstable patient. There is clinical deterioration, you can see. What are the initial things you will do? And we have to mark the multiple options. First, that in the patients of necrotizing acute pancreatitis, we have to go for the step-up approach. What is that step-up approach? Initially, if there is suspicion of infection or patient is having established infection with clinical deterioration, in such cases we go for percutaneous catheter drainage or endoscopic intraluminal drainage. So what we follow here, we go for step-up approach in patients who are having necrotizing acute pancreatitis. So in this, first percutaneous catheter drainage, or we go for endoscopic intraluminal drainage. How we perform this endoscopic intraluminal drainage? We have to insert the stent and we perform suction also endoscopically. Imagine if this is not useful, then followed by minimally invasive necrosectomy. So what? Followed by minimally invasive necrosectomy. Okay. If you see, traditionally it is taught that the definitive treatment for infected pancreatic necrosis is what? Laparotomy, debridement and necrosectomy. But we are going to perform it very late. Initially, we have to start with IV antibiotics. And what are the antibiotic group which are preferred? Antibiotics we start, and the carbapenems are the drug of choice. After starting IV antibiotics, we go for percutaneous catheter drainage or endoscopic intraluminal drainage, followed by we go for minimal invasive necrosectomy if it's required. Straight away, we are not going for laparotomy, debridement and necrosectomy. Okay. And MRI to visualize the pancreatic duct, that's not done here. So what are the initial things you will do? Laparotomy and necrosectomy, it's not done initially. MRI to visualize the pancreatic duct, not required. Percutaneous aspiration of fluid under image guidance, yes, it's done. IV antibiotics, imipenem, meropenem means carbapenems we give. So correct answer for this question is what? Option number C and D. C and D, these are correct. Now see what's written in subsystem related to management of necrotizing acute pancreatitis. Once infection has been demonstrated, IV antibiotics should be started. And what's the first option? Carbapenems. Clear? Alternative therapies we can give quinolones, metronidazole, third generation cephalosporin and piperacillin. We discussed that definitive treatment of infected pancreatic necrosis, that is surgical debridement. This is surgical definitive treatment which is performed at very late stage, not initially, plus necrosectomy. Okay. So initially what is preferred? Percutaneous drainage under ultrasound or CT guidance, or endoscopic drainage in which we are going to insert a large bore stent and possible endoscopic debridement with or without percutaneous drainage. And if you are going to use this approach, it can avoid operation in majority of the patients. Clear? So for these patients, minimally invasive operation will be more straightforward and it is preferred. Which of the following is the correct statement related to carcinoma stomach? So this question is related to carcinoma stomach, specifically related to one classification system. And what's the name of that classification system? You must be knowing. It's Lawrence classification. It's related to Lawrence classification. Okay. Now see the options. Most of the cases of carcinoma stomach are hereditary. No. Majority of cases of carcinoma stomach are sporadic. Sporadic, not hereditary. So this is wrong. E-cadherin loss causes diffuse variety. Yes, there are two varieties according to Lawrence classification, intestinal variety and diffuse variety. In intestinal variety, there is APC gene mutation and P53 and P16 mutation, which is also seen in diffuse variety, right? So E-cadherin loss causes diffuse variety, that's correct. Intestinal variety is caused by WNT mutation pathway. No, it is P16 or P53 mutation pathway. Depth of invasion has no prognostic value. No. In GI malignancies, we know that the T staging is mainly dependent on the depth of invasion. So it is having prognostic value. So this is correct. Option number C is incorrect. D is incorrect. So correct answer for this question is B. Lawrence classification is important. Have a look. So according to Lawrence classification, there are two varieties, intestinal variety and diffuse variety. How to remember? Let me tell you. This intestinal variety is the classical variety. Classical variety means you know that most of the cases of carcinoma stomach are seen in males. Which males? Elderly males, means the age should be approximately 50 to 60. And the most common site is distal part. There is well-defined gland formation. There is hematogenous spread. These are the classical features. But if atypical features are there, means if it's more common in females, if the most common site is proximal part, there is poor gland formation. So these are atypical findings. So how you can imagine intestinal variety is classical variety and the diffuse variety is atypical variety. So we discussed it is more common in males and elderly in 5th to 6th decade. Most common site in intestinal variety, distal part. There are environmental risk factors. Well-defined gland formation is there. Which gene mutation? APC gene mutation, and this is epidemic. What means it's scattered. And diffuse variety, atypical, so more common in females, young patients. Proximal part is more commonly involved, means fundus is the most common site. Here, familial risk factors, gland formation is poor. So what is the typical variety seen? There is signet ring variety which is seen. What kind of spread? Not the hematogenous here. Most commonly there is lymphatic or transmural spread, and this is the question option. Decreased E-cadherin leads to diffuse variety. This is endemic. There is one similarity between these two, and what's the similarity? In both there is inactivation of what? P16 and P53. So this is Lawrence classification. Now see the question number 15. A patient underwent surgery 1 year back. Now presented with fatigue. There is fatigue. Investigation suggesting macrocytic anemia. Which of the following parts resected cannot cause these conditions? Macrocytic means this patient RBC is a bit larger. This is a case of megaloblastic anemia, and you know what's the cause? It's because of vitamin B12 deficiency, right? We take B12, especially B12 is present in animal protein. So whenever you take this B12 of cobalamin, this cobalamin is released by the action of acid. In stomach, there is acid, HCl. So what? Free cobalamin is there. Free cobalamin. And this free cobalamin, it is going to bind with a binder, R binder. So it is going to make a stable complex. Cobalamin R binder complex. You know that the parietal cells of stomach are also going to secrete which factor? Intrinsic factor. So whenever this stable complex reaches duodenum, pancreas are going to secrete a protease. Clear? So pancreas are going to secrete a protease which is going to lyse this complex, and now the cobalamin is released, and this cobalamin in duodenum, now it's going to bind with intrinsic factor. And you know, this cobalamin and intrinsic factor complex, it is absorbed in terminal ileum. This is absorbed in terminal ileum. Clear? So what are the organs involved directly or indirectly? Obviously stomach, duodenum, the secretion of pancreas, what secretions? Proteases, and ileum. So even if you resect jejunum, what? It doesn't affect the B12 absorption. So which of the following part resected cannot cause this condition? Obviously it's C, that is jejunum. See, many times questions are asked in relation to kind of anemia in gastrectomy. So most common metabolic complication after gastrectomy, that is iron deficiency anemia. Most common metabolic complication. Whenever more than 50% of stomach is removed, then only patient is going to develop what? Megaloblastic anemia. And you know why? Because stomach is going to secrete intrinsic factor, and by which cells? Parietal cells. So see, there is dietary intake, especially in the animal protein, there is cobalamin or B12, and it is bound to some enzyme. So by action of HCl, it is released because the pepsin is going to digest the binding protein. So this free cobalamin, it is going to form a stable complex with R binder, and there is another factor which is being secreted by parietal cells, that is intrinsic factor. So what happens? The pancreas is going to secrete a protease. This protease, it is going to degrade or it is going to separate R binder from B12, and this B12 then binds with intrinsic factor, and this intrinsic factor with B12, this complex is absorbed in the terminal ileum. Let me tell you, if it's free cobalamin, it won't be absorbed. So only B12 attached to intrinsic factor is absorbed. So what are the organs involved? Stomach, duodenum, terminal ileum, and which organ is secreting that protease? The pancreas. Question number 16. A visible mass in epigastrium with CD117 positive. Marker is CD117. It's positive. Okay. Cytokeratin and S100 negative. You know that cytokeratin, it's positive for epithelial neoplasm like carcinomas, and S100, its diagnostic value is there for which malignancy? Malignant melanoma. S100 is positive for malignant melanoma. You know, this CD117, it's a marker for which particular tumor? GIST. And GIST is going to express tyrosine kinase receptor. And what's the name? c-KIT. It is going to express tyrosine kinase receptor. Tyrosine kinase receptor. That is c-KIT, and the marker is CD117. What are the two new markers for GIST? One is DOG1, detected on GIST1, that is DOG1, and second is protein kinase C theta. Protein kinase C theta. Okay, you know that GIST, what is the most common site? Obviously stomach. The full form is gastrointestinal stromal tumor, so its origin is from stroma, interstitial cells of Cajal. So what is the route of spread here? It behaves like sarcoma. So there is hematogenous spread. Most common site of metastasis is liver. Lymphatic spread like carcinoma is not seen. Clear? So mass in epigastrium, which is CD117 positive. Correct answer for this question is option number A. Question number 17. Let me tell you, two questions are asked almost every year. One related to pneumoperitoneum or perforation peritonitis, and second, it's related to tension pneumothorax. Every year in each and every paper, this question is asked. And traditionally, they are asking what? This free air under the right dome of diaphragm, pneumoperitoneum, and one clinical question related to tension pneumothorax. So here you can see patient undergoing treatment for peptic ulcer disease, right? Presents to emergency, X-ray shows the gas under diaphragm. It means what happened? There is perforation. What step would you do next? So whenever a patient of perforation peritonitis comes to you, obviously these patients are in the state of shock, most of them. So what first? We resuscitate these patients. So what we give IV fluids, we insert Ryle's tube, we insert Foley's catheter, and whenever patient urine output becomes 1 ml per minute, then only means after stabilization and resuscitation only, we take this patient for laparotomy. So obviously we go for IV fluids. We don't require CT if X-ray is showing pneumoperitoneum. Exploratory laparotomy, yes, after IV fluids is done. Upper GI endoscopy, it's not done in cases of perforation peritonitis. Clear? So what are the options which are correct? Option number A and option number C, because this patient is having perforation peritonitis. And in peptic ulcer, you tell me what is the most common site of peptic ulcer? First part of duodenum. This is first part of duodenum. And whenever there is duodenal ulcer perforation, what is the treatment? Here is the perforation. So what is the treatment? We take the omentum and we perform omentum patch repair, that is also known as modified Graham's repair. So correct answer for this question is option number A and option number C. Question number 18. In the given below X-ray, obstruction is seen in which of the following part? So you can see this is the typical X-ray. This was asked many times before. And what's the name of this sign? This is coffee bean sign. And it is seen in which type of volvulus? Sigmoid volvulus. What kind of sign is seen in cecal volvulus? Here, there is kidney bean sign. There is kidney bean sign, or there is comma-shaped cecum. Comma-shaped cecum. Okay, so see the options. Option number A, small bowel obstruction due to bowel perforation. No, because in such cases you will find what? Pneumoperitoneum. Large bowel obstruction by fecalith, this kind of sign is not seen. In sigmoid volvulus, this is the sign which is seen, and this is known as coffee bean sign. Coffee bean sign. So this is correct. Option number C. There is other two signs, bent inner tube, and what else? There is omega sign. So correct answer is option number C. So here you can see this kind of appearance. What kind of volvulus is seen in sigmoid volvulus? Rotation. What kind of rotation? It can be clockwise as well as anti-clockwise, but more commonly it is anti-clockwise. Apart from this coffee bean sign, you can see there is bent inner tube and there is omega sign. If we go for barium enema, then there is bird beak sign, ace of spades sign, bird of prey sign. These are important radiological signs which are asked. Match the following. What is football sign? This is the oval shaped lucency seen in supine films, especially in infants who are having large pneumoperitoneum. So in which case football sign is seen? Pneumoperitoneum, oval shaped lucency in supine film. Rat tail sign. So there is distal tapering of esophagus, and typically it is seen in achalasia cardia. There is rat tail filling defects which is seen in carcinoma esophagus. Then there is inverted umbrella sign. What happens in inverted umbrella sign? There is thickened IC valve, rigid cecum, and narrowed terminal ileum. So that is inverted umbrella sign. This is also known as Fleischner sign. And this is seen in which condition? Tuberculosis. String sign. So see, if string sign is mentioned, it is seen in hypertrophic pyloric stenosis also, and the string sign of Cantor is seen in tuberculosis as well as Crohn's disease. So since we have to choose one, string sign on barium study, especially barium meal, it is seen in pyloric stenosis, and if it's string sign of Cantor, this is seen in both tuberculosis as well as Crohn's disease. So what is the correct answer here? You can see A4, B2, C1 and D3. So correct answer is option number A. See the image based questions which are asked here. You can see this is the rat tail sign, distal tapering because of spasm of LES in achalasia cardia. Here you can see thin stripe of contrast within the lumen. This is hypertrophic pyloric stenosis. And what's the name of sign? This is known as string sign. Okay, thin stripe of contrast within the lumen. We discussed that string sign of Cantor is seen in Crohn's disease as well as GI tuberculosis. In this image, you can see that there is oval shaped lucency in this supine film, and this is seen in large pneumoperitoneum, especially in which patients? In infants. And what is inverted umbrella? Here you can see this is the umbrella which is inverted. So what? Thickened IC valve, rigid cecum, and narrowed ulcerated terminal ileum. Clear? So this is the Fleischner sign. This is known as Fleischner's sign. It is also known as inverted umbrella sign. Inverted umbrella sign. And this is typically seen in barium meal follow through. In which patients? The patients who are having GI tuberculosis. And you know what is the most common site of GI tuberculosis? It's a ileocecal region. That is ileocecal region. Question number 20. Again related to tuberculosis. Which of the following is not a mode of spread of abdominal tuberculosis? So what's the most common route of spread? See, the first organ affected is lungs. And after that, what happens? There is production of infected sputum. And swallowing or ingestion of that infected material leads to tuberculosis. That's the most common route. Apart from this, it can occur because of hematogenous route. It can occur because of spread from contiguous organ like mesenteric nodes. Clear? It can occur because of close contact with animal having tuberculosis. But feco-oral route, it's not a mode of spread. So it can be hematogenous, it can be contiguous spread from mesenteric nodes. It can occur because of close contact with animal having tuberculosis, because you must be knowing bovine tuberculosis, if there is infected raw material, ingestion of that can lead to tuberculosis, that is primary intestinal tuberculosis. So all these three can be the modes, but feco-oral route is not the mode. So correct answer for this question is option number B. So see the modes of spread of abdominal tuberculosis. First, by ingestion of food which is contaminated with tubercle bacilli causing primary intestinal tuberculosis. And whenever patient is having involvement of lungs and there is production of sputum that contains the bacteria and then there is tuberculosis, this is secondary. This one is the most common route. There can be hematogenous spread from lungs. It can occur because of neck nodes also, because what happens? There is tubercular cervical lymphadenitis in 5 to 10% cases. And how this form of tuberculosis is going to spread? Through lymphatics. And from fallopian tubes, there can be retrograde spread of tuberculosis, and it can involve the peritoneum in 10% cases. So these are the modes of spread. There can be spread of tuberculosis by close contact with the animal having tuberculosis. So we discussed what is the most common site of abdominal tuberculosis. It is the ileocecal region. That's the most common site. And earliest disease activity is seen in which particular layer? The earliest disease activity, it is seen in submucosa. Submucosa. So correct answer for this question is option number A. Question number 22. A 32 years old female diagnosed with tumor in proximal transverse colon. Proximal transverse colon. What are the vessels ligated while doing extended right hemicolectomy? So whenever the malignancy is in the proximal transverse colon, we are going for extended right hemicolectomy. So first, which organs are removed? Yes, terminal ileum, cecum, ascending colon, hepatic flexure of colon, and what? Proximal 2/3 of transverse colon. Which part of bowel is removed? Terminal ileum, cecum, ascending colon, hepatic flexure, and proximal 2/3 of transverse colon. And if you have to remove this much of bowel, then which vessels you are supposed to ligate? Obviously, ileocolic, right part of colon, so right colic. And since you are going to remove proximal 2/3 of transverse colon, so obviously what? Middle colic artery at its base. See the diagrammatic representation. So first, what we are going to remove? We are going to remove starting from which part of bowel? A till G. From A till G. This part is removed. Now you can see which arteries we are going to ligate. So we are going to ligate what? This ileocolic artery, this right colic artery, and middle colic artery. Where? At its base. Ileocolic artery, right colic artery, middle colic artery at its base. So this is extended right hemicolectomy. Okay, now see the options. So if you see the options, first ileocolic, right branch of middle colic, no. Base of middle colic. Ileocolic, right colic only, no. Middle colic only, no. It's ileocolic, right colic, middle colic artery at its base. At its base. So correct answer for this question is option number C. See question number 23, another related question. After appendectomy of re-exploration, edit kar dena. Now see the question number 23, again a related question. After appendectomy, exploration was done for the bleeding. There was bleeding, so exploration was done. Ligation of which artery is beneficial? So if you do appendectomy, yes, obviously the site of bleeding will be from which particular artery? Appendicular artery, and you know that appendicular artery is a branch of which particular artery? Ileocolic. So ligation of which particular artery will be beneficial? Obviously it's ileocolic artery, because appendicular artery, it's a branch of ileocolic. What? Appendicular artery, it's a branch of ileocolic artery. Ileocolic artery. Clear? So correct answer for this question is C. Question number 24, again a repeat question, easy question. Which of the following should not be given before splenectomy? You know what's the function of spleen? Spleen helps in phagocytosis of capsulated organisms, right? After splenectomy, there is OPSI, overwhelming post-splenectomy infection, which is easy to prevent, difficult to treat. Why? Because how much is the mortality? 40 to 50%. So how you are going to prevent OPSI? With the help of vaccination or immunization. And vaccination or immunization is done against these three capsulated organisms. Most commonly, infection is caused by strep pneumoniae or pneumococcus. The second is Neisseria meningitidis or meningococcus, and the third is Haemophilus influenza type B. So we don't give any kind of vaccination against typhoid in the patients in whom splenectomy is being planned or has been done. Now, two types of vaccination. See, if it's elective splenectomy, we have to give the vaccine at least 2 weeks before surgery in cases of elective splenectomy. And if it's an emergency splenectomy, means a trauma patient was brought to your emergency, you performed splenectomy. So after splenectomy, as early as possible, you should give the vaccine against these three capsulated organisms. So correct answer for this question is option number A. Question number 25. Similar question has been asked in AIIMS itself, only the image was different. This time there was a different image. A patient presented with hematuria. CT scan mass in left kidney is shown below. Here you can see this is the kidney, and here you can see the mass. In this mass there are relatively black areas also. Clear? So which areas are relatively black? The areas which contains fat, because fat is having minus 20 Hounsfield unit or less on CT, appears relatively black. And presence of fat is diagnostic of which particular tumor? Yes, angiomyolipoma, because if you are going to break it, angio means it is composed of matured vessel, myo means muscle, lipoma means fat. So here, presence of fat and absence of calcification is diagnostic. It differentiates it from RCC. So correct answer for this is option number B. Here also there is no fat, no fat, no fat. In polycystic kidney disease or cyst, obviously there will be cystic lesion, right? So here this is the mass having relatively black area, that is fat. So correct answer for this question is option number B, angiomyolipoma. So angiomyolipoma is only benign tumor that is confidently diagnosed on cross-sectional imaging. Why? Because of presence of fat. And you know, it's having a value of minus 20 Hounsfield unit or less. Clear? So this is diagnostic hallmark, presence of fat. Now question number 26. In a patient of carcinoma prostate with high Gleason score, bone scan was done. Bone scan showed increased uptake with bones and reduced in kidney and soft tissues. This is reported at super scan. So what is the definition of super scan? So bone scan in which there is excessive skeletal radioisotope uptake. What? Excessive skeletal radioisotope uptake in comparison to or in relation to soft tissue, along with absent or no uptake in genitourinary tract. So excessive uptake in skeletal, ये edit कर देना. So excessive skeletal radioisotope uptake in comparison to soft tissue, and no uptake or faint uptake in genitourinary tract. This is the definition of super scan. Why? Because these patients are having osteoblastic secondaries or osteoblastic lesions. Okay. So why it is reported as super scan? Just because of increased bone uptake? No. Just because of decreased uptake in kidney? No. Increased because of carcinoma prostate? No. Why? Because these patients have osteoblastic lesions. And you know, CA prostate is the most common malignancy responsible for bony metastasis in males. CA breast is the most common malignancy responsible for bony metastasis in females. In CA prostate, what kind of secondaries? There are osteoblastic secondaries, and in CA breast, what kind of secondaries are seen? Osteolytic, more common than osteoblastic. But even if the question is asked, most common primary for osteoblastic secondaries in females, again the answer is what? CA breast. So correct answer for this question is option number B.